Yeah, hello, Namaskar. I am Dr. Dinesh, and in this lecture we are going to discuss pharmacology CBT-2 for FMGE. So let's start with the question number 1. Penicillinase production. Penicillinase production by strain of Haemophilus influenzae, H. influenzae, Moraxella catarrhalis, Neisseria gonorrhoeae. All these are the bacteria which are having the penicillinase enzyme producing property. Because of penicillinase, there will be resistance against penicillin G. Which one of the following antibiotic is most likely to be effective against all such strains, each of above organism? So bacteria showing the resistance due to penicillinase inactivating enzyme production. Which antibiotic is most probably effective against all these strains? If you see the options, ampicillin is one of the penicillin. Ceftriaxone is one of the third generation cephalosporin. Gentamicin is one of the aminoglycoside. Piperacillin is one of the penicillin. Because there is penicillinase production, so penicillins are not effective. Against the penicillinase production, some of the penicillins are effective. These penicillins are like cloxacillin, oxacillin, napsillin, dicloxacillin, and methicillin. These penicillins are effective against these. Rest of the penicillins are not effective. These penicillins are also called as penicillinase resistant penicillins. These are cloxa, oxa, napsillin, diclox, and methicillin. You can remember by the condom. These are effective. But ampicillin, piperacillin, they are not effective. They are extended spectrum penicillin, but not effective for this. Aminoglycosides are not showing the effect against all these organisms. Aminoglycosides are effective mainly for gram-negative bacilli. They are effective for gram-negative bacilli. Third generation cephalosporins, they are effective for these. They are effective for all these. They are effective for H. influenza. They are effective for Neisseria, Moraxella. In all these are effective. That's why they are very good drug for meningitis. In the meningitis patients, we use the ceftriaxone. We can combine ceftriaxone with the these aminoglycosides, but first choice will be ceftriaxone. So ceftriaxone is the effective drug against all these. That's why in gonorrhea, in meningitis, it is the drug of choice, injectable antibiotic. Next question. 40-year-old patient, white women, report that this has occurred several times over the last year despite the antibiotic treatment. She is taking the antibiotic treatment, but this has been repeatedly seen. Upon reviewing the medical records, you notice that she has been treated for recurrent UTIs, which has been caused by the drug-resistant strain of Klebsiella. So UTI is recurrent and Klebsiella is the strain, which is also showing the extended spectrum beta-lactamase enzyme activity. So there are some bacteria which are showing this activity like E. coli, Klebsiella. These are showing the ESBL activity, extended spectrum beta-lactamase enzyme activity. In ESBL, remember bacho, in ESBL, which enzymes are there? So these bacteria are having the penicillinase enzyme. These bacteria are having the cephalosporinase enzyme. So you can see some of the beta-lactams will not be effective. These are having the monobactamase enzyme. All these enzymes are present in these bacteria. All these enzymes are present. So that's why penicillins are not effective. Cephalosporins are not effective. Even the monobactam is not effective. Monobactams are not effective. So penicillin, cephalosporins, monobactams are not effective. But in ESBL, in these Enterobacteriaceae like Klebsiella, E. coli, these are Enterobacteriaceae group. In these Enterobacteriaceae, even if they are showing the ESBL activity, carbapenims are the most effective drugs. Carbapenims are the most effective drug. Out of these, which is the carbapenem? Aztreonam is a monobactam, not effective. Cefepime is a cephalosporin, not effective. Amikacin is the aminoglycosides, not effective. But imipenem, carbapenims are very effective for ESBL resistance bacteria. So imipenem, meropenem, these are carbapenims and they are the most effective drug for this purpose. Right? And the patient is on beta-lactam drug. So carbapenims are the beta-lactam. Even if you want to give the amikacin showing some activity, they are not very effective drug, but amikacin is not a beta-lactam. That's why amikacin cannot be the answer. It's not a beta-lactam. Imipenem is the beta-lactam. Next question. 32-year-old male physician from Paris is planning to participate in a medical conference in India. In addition to hepatitis vaccine, he also wished to take the prophylactic medicines for other serious illness he may encounter during his visit. You advised him a medication that will serve as a chemoprophylaxis of malaria, because malaria risk is there. The prophylaxis should start 1 week before and it should be continued for 1 week after, 2 weeks, 3 weeks or 4 weeks after returning back. See, the first important drug in these patients, we use the chloroquine, and it should be start 1 week before and it should be continued 4 weeks after return. 1 week before and 4 weeks after return. So it is 4 weeks after returning you should continue. Then it is the best. But if chloroquine resistance is there in CHQ resistance patients, then we have the two more other options. One is doxy and the another is mefloquine. Doxy or mefloquine. Doxycycline is good if the journey is for less than 6 weeks, and mefloquine is good if the journey is for more than 6 weeks. Because you cannot give doxycycline for the patients who are visiting for more than 6 weeks journey. It is not good drug for long term. Then you can give the mefloquine. So in chloroquine resistance patients, doxy and mefloquine, but otherwise chloroquine. But these should start 1 week before and they should continue 4 weeks after return. But doxycycline is the drug which is fast acting. It can be started 1 to 2 days before as well. Doxy. It can be started 1 to 2 days before also. So this is for prophylaxis of malaria. Next, a young girl has paroxysmal attacks of rapid heart rate with palpitation and shortness of breath near to her exam date. So this is typical case of anxiety. She is having the anxiety, palpitation, restlessness before exam. That means performance anxiety. Performance anxiety. These are typically attacks. Panic attacks were diagnosed. So these are causing the panic attacks, anxiety attack. Now, which of the following drug would be most suitable for prophylaxis to prevent the tachycardia? Now our aim is to prevent these panic attacks in the future. Repeated panic attacks are there. This patient should not suffer these panic attacks in the future. So which drug you will start? So basically in performance anxiety, to prevent these panic attacks, what will be the best option? Fluoxetine is a good drug for anxiety. Fluoxetine is a good drug for anxiety, but that is not a good drug for this type of patient, because this patient is not suffering of chronic anxiety. It's a case of acute anxiety attacks, frequent attacks are there. So it is not the best option. Adenosine is again not a best option for this patient. Adenosine is just to control the tachycardia in some patients, but that is not for prophylaxis purpose. That is for acute condition. Alprazolam is again benzodiazepine sedative drug. You can never use the sedative in these patients. In this patient only you have the two options, either fluoxetine or propranolol. But in performance anxiety, it's not a chronic anxiety, so fluoxetine is not having any role. Fluoxetine is a good drug for chronic anxiety patients. Propranolol is the best drug in these patients because there is sympathetic stimulation. And panic attack is there. Tachycardia is the main problem. To control the tachycardia, to prevent these panic attacks, propranolol will be the best drug in these patients. If she is not suffering of tachycardia, repeated panic attacks are there, then panic disorder was diagnosed, then you can start the fluoxetine. But this is not a case of panic disorder. This is a case of performance anxiety due to exams. If you know the trigger, exam is there, then it will be over after exam. So just give the propranolol before exams, and that will prevent these anxiety attacks. No need to give the regular medications for these type of patients. Performance anxiety. Best treatment. Next question. Best treatment for this condition is. So it is a back of the patient. In the back you can see these vesicles, and these are painful vesicles. They are painful vesicles. Typical case of herpes zoster. Typical case of herpes zoster. By these lesions only we can identify this is herpes zoster. But in history you need to ask painful. That which drug is best for this? So mupirocin is for MRSA, not for this. It is for bacteria. Tenofovir is not for this. Tenofovir is the drug for HIV and all, HIV, hepatitis B. Ganciclovir, valacyclovir can be used for hepatitis. Ganciclovir is used for cytomegalovirus chorioretinitis. Cytomegalovirus chorioretinitis. Well, cyclovir is the drug which is used for herpes simplex, herpes zoster. It is the ester prodrug of acyclovir. Ester prodrug of acyclovir that is used for herpes simplex, herpes zoster, varicella zoster. So valacyclovir is the drug which is best drug for this. Acyclovir, valacyclovir both are important. Valacyclovir is better than acyclovir because of the better oral bioavailability. Okay, next question. A child brought to the emergency with seizures. Child brought to the emergency with the seizures. Airways has been secured. That is the first thing we need to do in the epilepsy seizures. Anti-epileptic was given. What will be the first line drug to control the seizures? In emergency, if the patient comes in the seizure, the first line drug we use is the benzodiazepines always. Benzodiazepines are the most preferred option. So out of these, if you see the option, diazepam is a benzodiazepine. Sodium valproate is not a benzodiazepine. That is not a drug for acute seizures. That is the drug for GTCS if repeated seizures are there. Phenytoin is again can be used in emergency, but that is not a choice of drug. Phosphenytoin IV drip we use, but that is not a choice. Phenobarbital is a barbiturate injection that can also be used, but not a choice. The choice of this drug is benzodiazepines, diazepam. So we prefer two drugs, lorazepam, diazepam. Lorazepam, diazepam, these are the drugs we use to control the seizures in the emergencies. Or we can have the midazolam also. Midazolam. These are the benzodiazepines. Next question. A female came to the general OPD with pain and inflammation of many joints. There is pain and inflammation of many joints. After examination and further investigation, she was diagnosed as rheumatoid arthritis. Rheumatoid arthritis. Drugs prescribed for this is methotrexate. That is the first choice DMARD. That is the first choice DMARD in these patients. This is the first choice DMARD. Which of the following is a mechanism of action of this DMARD or this methotrexate? Options are xanthine oxidase inhibitor. No, that is for allopurinol. That is for allopurinol, not for this. Thymidylate synthase enzyme inhibition. No, that is for 5-fluorouracil. Ribonucleotide synthase inhibitor. No. These are for DNA RNA inhibitors. DHFRase inhibitors. Yes. DHFRase inhibitor, dihydrofolate reductase enzyme inhibitor. Dihydrofolate reductase to decrease the tetrahydrofolate synthesis, and because of that there will be side effects also. It is used for treatment, but side effects are also there. That's why we use the folinic acid. Folinic acid is given for decrease the risk side effects, either high dose folate or folinic acid. Methotrexate. Next question. A patient of pancreatic carcinoma, you give the morphine for relieving the pain of this patient. After few days, the pain is not relieved as it was relieved earlier. You know, tolerance is very commonly seen in the opioid. Tolerance. And against all the actions, tolerance seen. In all actions, you will see the tolerance is seen. Except one action, and that is constipation. Except constipation, tolerance is very commonly seen. So even for analgesic effect, tolerance is there. So how the tolerance develops? Desensitization of the opioid receptor? Yes. Down regulation, desensitization of the opioid receptor. Decrease the absorption is there? No. Pain intensity has increased? No. Same patient, pain intensity is not increased. Opioid receptors are upregulated? No. Upregulation will reverse the tolerance. Down regulation will decrease the effect. That is the tolerance. So desensitization or down regulation of the receptor is causing the tolerance, and that's why the patient is not having relief in the pain. Otherwise, morphine is a very strong drug. It can relieve the pain easily in the cancer patients as well. Next question. The drug used for chemotherapy induced nausea and vomiting. Chemotherapy induced nausea and vomiting. There are many drugs we use. The first drug we use is the cetron. The second important drug we give is the pitant. The third important drug we give is the steroids. These are the three very important drugs. But other than these, we can also use the two drugs. One is cannabinoid receptor, Nabilone, cannabinoid Nabilone, or we can use the olanzapine, antipsychotics also. Nowadays, even quadruple therapy, we use the cetron, pitant, steroid and olanzapine, and these are very effective. So you can see this is the option which is best. These are not the preferred option. Domperidone is not a preferred option. Even metoclopramide can be used, Dexa can be used, but domperidone is not a preferred. And in this regimen there is no cetron, no pitant. How it is possible? In this we don't have the role of these drugs very common. Doxylamine, no. So that's why first option is correct option. Chemotherapy induced nausea vomiting, cetrons, pitants, steroids, cannabinoids and olanzapine. These are the drugs we use. So cetrons are overall drug of choice, pitants are for late onset chemotherapy, onset vomiting, drug of choice, pitants, late onset. Next question. 36-year-old man came with a reddening of conjunctiva, red conjunctiva, suspected of taking some drug substance abuse. On examination, having the increased pulse rate and decrease in the blood pressure. Pulse is high, BP is low. Psychomotor performance is there. It means causing some euphoria, and pupil is normal. There is no change in the size of pupil. These are likely to be due to ethyl alcohol. Ethyl alcohol, first, it is not causing redness of conjunctiva. Second thing, it is not causing psychomotor performance. Mostly you will see it is causing mild euphoria, but then it is sedative. And it can change the pupil size as well. So it is not showing any symptom of ethyl alcohol. Second is marijuana, that is cannabis. In cannabis, these are the characteristic symptoms. All characteristic symptoms are there. Redness of conjunctiva, psychomotor performance increase, pupil size is normal, BP fall but pulse rate will be high. In cocaine, BP will be high, heart rate will be high, as well as pupil will be dilated. Why? Because it's a sympathomimetic drug, cocaine. It's a sympathomimetic drug. Heroin is a morphine group of drug. In this you will see the BP and heart rate is down and the pupil will be constricted. If the pupil size is not changed, then the doubt is marijuana. In marijuana, pupil size will not change. The size of the pupil is same, but redness of the conjunctiva is there. And mild euphoria is there. Addictive drug. Bhang, charas, ganja. Next question. Chronic alcoholic suddenly stops drinking and getting in the delirium. It means this delirium is due to alcohol withdrawal. This is called as delirium tremens. This is called as delirium tremens. It is the sudden acute alcohol withdrawal. It occurs after 24 to 72 hours. Within 24 to 72 hours. After 24 up to 72 hours, you can see the acute alcohol withdrawal, delirium tremens. There will be confusion, disorientation, autonomic disturbances, visual hallucinations. What is the management of this patient? So in these patients, the best drug to manage is benzodiazepines. But because the patient is chronic, always combined with the thiamine. The best treatment for these patients will be benzodiazepines plus thiamine. Out of the benzodiazepine, lorazepam is the safest, because lorazepam is safe in the liver disease patient. So lorazepam plus thiamine will be the first therapy in these patients. Then we will shift the patient to chlorodiazepoxide, but this is the first drug. So lorazepam plus thiamine will be the best treatment for these patients. Next, 53-year-old women recently diagnosed with gouty arthritis. Started on a drug. The drug inhibits leukocyte migration as well as phagocytosis, controlling the inflammation. Secondary to inhibition of tubular polymerization. It means the main aim is inhibit the polymerization of the tubules. Microtubules inhibit. Main aim is microtubules inhibit, but additionally it inhibits the phagocytosis, leukocytes migration as well. Which drug is most likely causing this? So it is anti-inflammatory drug. It is anti-inflammatory drug. So this is out. This is out. This is out. These are for chronic, they are not anti-inflammatory. Allopurinol decrease the uric acid synthesis. Probenecid causing the excretion of uric acid. Now these are anti-inflammatory, but the drug which inhibit the tubulin microtubules is colchicine. Interleukins are inhibited by the prednisolone. Colchicine is tubular polymerization inhibit, microtubules inhibit, and inhibiting the chemotaxis. It is the good drug, but the risk is there. What is the risk? That is causing the bone marrow suppression. It is causing bone marrow suppression. That is the risk. Secondary infections are there. That's why NSAIDs are preferred. In most of the patients, NSAIDs can be managed, can be used for management. But colchicine is used for refractory acute conditions when the pain is not controlled. The common side effect is diarrhea, but bone marrow suppression is the big risk. Next, which of the following agent is drug of choice for NSAID-induced peptic ulcer? You know, NSAIDs are inhibiting the COX enzyme. Via inhibiting the COX-1 enzyme, they can decrease the prostaglandins and they can inhibit the gastroprotective effect. If the gastroprotection will be less, there is risk of erosion, gastric ulceration. The most specific drug for this patient, the specific drug for this patient will be PGE1 analog misoprostol. But it is the drug of choice they are asking. In any peptic ulcer, if any peptic ulcer, any etiology, the drug of choice to treat the peptic ulcer is always and always PPI. Don't forget this. So PPI is a drug of choice for peptic ulcer of any etiology for treatment. A specific drug used to prevent these ulcers could be misoprostol. So in this the answer will be lansoprazole, PPI. Misoprostol is not the drug of choice, that is the specific drug. Megaltrate is the antacid, that is just to control the symptomatic relief. Lentidine can be used but not a choice. H2 antagonist. Lansoprazole is the PPI, proton pump inhibitor, and they are the drug of choice. Next question. Which of the following drug does recommend the first line therapy? Recommend as a first line therapy for overweight patient with type 2 diabetes mellitus. Type 2 patient, overweight patient, what will be the first line drug? In obese patients, we prefer the biguanides, one drug. But biguanides are not causing significant weight loss. So we also got some other drugs which are important as a first line. Nowadays GLP-1 analogs are there, which are also causing the weight loss, and they can be used as a first line. Now out of these, sitagliptin is the gliptin DPP-4 inhibitor that is not causing weight loss, that is a weight neutral drug, weight neutral. Pioglitazone is again not causing weight loss, even cause some edema. Gliclazide is the sulfonylurea that is causing weight gain. Semaglutide, that is one of the GLP. Semaglutide is one of the GLP, and that is the first oral GLP-1 analog. It is also approved for weight loss. Liraglutide, semaglutide. Liraglutide injectable, semaglutide oral, approved for weight loss as well. So they can be used as a first line drug in the obese patients. Still the first choice will be metformin, but that is not a significant weight loss. So semaglutide can be used, but metformin is not in the choice as well. So we will start with the semaglutide in these patients. Next is the most prominent and dose-related side effect of salbutamol is most prominent and dose-related side effect of salbutamol. So salbutamol is a beta-2 agonist, and what are the dose-related and most prominent adverse effect? The first and most common adverse effect will be tremors. It is dose-related and most prominent. Tremors. The second important is tachycardia. So tremors are most important. Then you will see the tachycardia, palpitation, restlessness, nervousness. Hyperglycemia is there, but that is not the first. Rise in BP is not there, that is hypotension, because beta-2 causing vasodilation. But normally hypotension is not seen. Only edema is seen, hypotension is not common. Very rarely it is seen. It can cause anxiety, restlessness, but not a choice, not a common. The first common is tremors, then there will be tachycardia, then there could be anxiety, palpitation, restlessness, hypotension, hyperglycemia, hypokalemia. Hypokalemia is also seen in these patients. Hypokalemia, electrolyte imbalance. So muscle tremor are the most common. Next question. 39-year-old male has recently started on monotherapy for mild hypertension. Hypertension, mild monotherapy as given. In most recent visit, the complaints of tiredness and not being able to complete the 3 set of tennis. Tiredness is there, not able to complete the 3 set of tennis. Which of the following drug is most likely causing this problem? So which drug the patient most probably taking? So out of these, albuterol is beta 2 agonist, that is not a drug for hypertension, so this is out. Atenolol is a beta blocker. Ephedrine is a beta agonist, again sympathomimetic drug. Phentolamine is the alpha blocker. So these 2 options are out. They are increasing the BP, they cannot decrease the BP. So these are out. Sympathetic stimulation is there. Now out of the beta blocker and alpha blocker, which can cause problem in the patients for tiredness and not able to complete the 3 set of tennis, it means muscle fatigue. So which is causing problem in the muscles? In the muscles, beta blockers can decrease the stamina. They can increase the fatigue in the muscles, because beta blockers inhibit the lipolysis. Inhibit the glycogenolysis. So there will be early fatigue. Beta blockers can cause early fatigue. That's why they are not used in the athletes. In athletes, they are contraindicated. Because beta blockers decrease the blood supply of the muscles, early fatigue of the muscles. Beta block means vasoconstriction, blood supply of the muscle will be less, early fatigue will be there. Lactate storage, pain will be there. That's why beta blocker should not be given for these patients. Not safe for athletes. This is all. Thank you for listening. Bye bye. Take care. Good luck.